Hi, good evening. I can't hear you.
Yeah, can you hear me now?
Yeah, clearly. So we'll start?
Yeah, sure.
Good evening, everybody. Welcome to this evening episode of Pursue, and today we have Pursue 6N, which is liver and GI pathology, and we are streaming live from Tata Medical Center, Kolkata. And today's topic is Mesenchymal Tumours of GIT, and to talk on that we have Dr. Paromita Roy, who is an MD IPGMER from Kolkata. She's a former fellow, University Health Network from Toronto, Canada, a senior consultant in the Department of Pathology, Tata Medical Center, Kolkata, with multiple publications in the national and international journals. And it needs to be mentioned that she is the person who actually set up the lab of Tata Medical Center. So she is an expert, a very senior consultant, and she will be talking on this topic. But before I ask her to take over, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Paromita Roy, ma'am, please share your screen and let us start. Yeah, I can see your screen here.
Yeah. It's visible, right?
Yeah. Just press that is removed. Let's pop up.
Yeah.
Thank you so much. Thank you so much. Yeah. Right, fine.
Yeah, so should I start?
Yes, please. Thank you.
Thank you so much for that kind introduction again. So today I'll be talking about mesenchymal tumors of the GI tract. And so this is our Bible for reporting these tumors, and it has a pretty comprehensive list of all possible mesenchymal tumors of the GI tract. But soft tissue tumors are a difficult group, really, because they are not very common. So we get a little flustered when we get a biopsy. And it's important to keep our eyes and mind open that these tumors may not be only from within this list. Practically any kind of mesenchymal tumor can occur in the digestive system. So what the WHO has done is classified the most commonly happening tumors into, based on the etiology or the site of the tissue of origin, into GIST, which is the commonest, the predominant group for both benign and malignant mesenchymal tumors of the digestive system. Then there are the adipocytic and myofibroblastic tumors, the smooth muscle and skeletal muscle group. Then there are vascular and perivascular tumors, neural tumors, and tumors of uncertain differentiation like PCOMA, angiomyolipoma, calcifying nested stromal epithelial tumors, synovial sarcoma, clear cell sarcoma, embryonal sarcoma, and the list goes on actually. It's we do rarely see tumors beyond the ones enlisted here. So one thing to remember is that when we have a large tumor in the abdomen, sometimes it's not clear to the radiologist what the site is, and that can really complicate things because retroperitoneal tumors arising from other abdominal organs would also come in your list of differentials when we are dealing with a biopsy. And we may not know that the primary site is a GI tract when we are trying to diagnose these lesions. So, however, this is an excellent review paper on the site-based classification of spindle cell tumors. It actually enlists the most common site of occurrence of the different mesenchymal tumors. And it's an excellent reference for if we want to narrow down our list of differentials. It's good to know what the common site of occurrence is. but it's of course not a foolproof system, as you can have rare presentations of rare tumors in any site group. So it helps us, but we can't be blinded to other options when we are trying to diagnose these lesions. So what is our approach to GI mesenchymal lesions? Once you know that you have a spindle cell lesion, spindle cell tumor in your biopsy, our job is to classify as to, are we dealing, of course, getting the diagnosis, and getting the diagnosis depends on, are we looking at a benign tumor or a malignant tumor? Because for spindle cell lesions, that's not a clear-cut differentiation. Some sarcomas can look very bland, and some benign tumors can have very pleomorphic and a very dirty look on the biopsy, which would seem aggressive. So knowing the morphology of the differentials is very important if we have to diagnose. So just looking at the slide, it may not be obvious to us whether we are looking at sarcomas or benign tumors. So benign tumors are more common, but both benign and sarcoma, mesenchymal tumors, are very rare, and most of them are GIST. So our first approach is to rule out a GIST if we have a spindle cell lesion on our biopsy. And then we have to be aware of all the morphological mimics, and here immunohistochemistry plays a huge role. And I will show you with some examples that choosing one or two IHCs can lead us into trouble. So it's wise to use a broader IHC panel. Of course, not an extensive IHC, which is not cost efficient, but I'll show you what our common IHC panel is and how we approach our cases. And lastly, knowledge of molecular classification. Soft tissue tumors like hematological malignancies has really advanced in the field of molecular biology, and if we are not aware of the common mutations, and if we don't substantiate our diagnosis with a mutation for certain entities, then both diagnosis and treatment of these tumors get limited. So it's good to have a pattern-based approach. So for tumors with a spindle cell morphology, the first is the commonest tumor, that is GIST, is what we will rule out. Some other common spindle cell lesions which occur in this site group are IMFT, or inflammatory myofibroblastic tumor. Desmoid type fibromatosis is not very uncommon. We also see benign lesions quite commonly, which are incidentally picked up on endoscopy, or sometimes the patient present clinically. These are inflammatory fibroid polyps, Leiomyoma, Schwannomas. Then we have the lipomatous group, biopsies where the tumor is looking obviously fatty. So there we have the lipoma and its malignant counterparts, liposarcoma, which we have to differentiate, and also angiomyolipoma, which is a part of the PICOMA group, can look very fatty and on biopsy. Then we have the tumors which have an epithelioid cell morphology. The commonest one in this group would be epithelioid GIST and epithelioid leiomyoma. Also tumors like PICOMA, granular cell tumor, clear cell sarcoma, these are not very rare, and they show an epithelioid morphology on biopsy. Vascular tumors like hemangioma, hemangioblastoma, angiosarcoma, and glomus tumors are also not very rare. They can show an obvious morphology of vascular pattern, or sometimes they can be quite solid. So they have a varied morphology, this spectrum of tumors. So for our spindle cell lesions, if we don't have a very good idea on morphology, and if we have to shortlist our differentials, then first we would use a panel of 5 markers that includes c-KIT or CD117, which is a GIST marker. CD34, it also highlights GIST, but it also covers other spectrum of tumors like inflammatory fibroid polyp, vascular tumors, to name a few. Desmin would cover myoid tumors, so both smooth muscle and skeletal muscle tumors can be excluded with Desmin positivity. Caldesmol is another smooth muscle marker. It's very sensitive and quite specific for smooth muscle, but we have to remember that quite commonly they stain positively in GIST. So that's a caveat for using Caldesmol. S100 picks up the neural tumors like Schwannoma and Mesenchymal and also the GNETs, the gastric neuroectodermal tumor. CK should be included in all panels for spindle cell lesions to rule out sarcomatoid carcinoma. And there are a few of the rare tumors which can focally express CK. I will show you when I discuss them in detail. In a second panel, we usually add, if the tumor is CK negative, we add a DOG1. If none of these markers are positive, we put a SMA to at least understand that are we dealing with a myofibroblastic differentiation, or is there any myoid differentiation in the spindle cells that we are seeing. And H-Caldesmon, as I said, is a small muscle marker. So even if the Desmin is negative, we can have some cases which are H-Caldesmon positive and Desmin negative, which helps to diagnose Leiomyoma. So, of course, there are variations to the panel depending on the morphology and the site and the age group, depending on whether it's a pediatric patient or an adult patient, our differentials are different. So there is variation to this panel, but usually if it's a standard spindle cell tumor of the GI tract, this is what our approach would be. So with that background, let me show you a few cases. This was a 35-year-old female who presented with dysphagia, and on endoscopic ultrasound, we can appreciate here a smooth mucosa-covered nodule, and the patient underwent a punch biopsy. This is the endoscopic ultrasound. We can see below the mucosa here a tumor. The patient underwent an FNA, and the smears show a bland tumor cells here, quite a bit of cytoplasm and kind of spindle-shaped elongated tumor cells. And this is the cell block that we had made. We can appreciate the bland spindle cells here and abundant eosinophilic cytoplasm. No appreciable mitosis, no atypia. So we did a IHC panel on this cell block and came to the diagnosis of Leiomyoma. If we did not have the advantage of doing IHC on the cell block, we might have been limited to call it spindle cell neoplasm. So Leiomyomas are very common mesenchymal tumors. This was an esophageal resection, so of the esophagus, and it can also be seen in other GI site groups like colon, rectum. Usually these are incidental. They don't really present with symptoms. They're small, but in the esophagus they can be symptomatic. One thing to keep in mind is when we are dealing with these biopsies and FNAs, we have to be very well aware of the clinical presentation, because sometimes a wrongly misdirected FNA biopsy can pick up normal smooth muscle cells from the gastric or the esophageal wall, and we may mislabel these as Leiomyoma and miss the actual diagnosis or another tumor that the patient may have underneath the muscle coat. So that is something we have to keep in mind, not to jump to the diagnosis unless we are very sure that it is neoplastic. So typical Leiomyoma has eosinophilic fibrillar clumped cytoplasm, cigar-shaped blunted nuclei which mimic gastrointestinal stromal tumors, and mitotic figures are rare. The IHC panel that we do on the cell block is we do a 3 IHC panel. That is, we use a myoid marker, Caldesmon, and we use a GIST marker, CD117, and we put in a neural marker, which is S100. So that's for our cell blocks and FNAs. Leiomyomas are positive for Caldesmon, Desmin, SMA, and Calponin, and they're negative for the GIST markers CD117, DOG1, CD34, and also S100. Leiomyoma sarcomas are the malignant counterpart of smooth muscle tumors. They are extremely rare, and how we differentiate them from leiomyomas is, of course, by the bizarreness, the severe nuclear atypia, mitotic figures, necrosis. And one thing to remember is sometimes when there are large abdominal tumors, we can have retroperitoneal leiomyoma sarcomas of female genital tract origin, which might mimic intestinal origin. So that is a more common presentation of leiomyoma sarcomas than primary ones of the GI tract. Another tumor of myeloid differentiation which can mimic leiomyomatous tumors are the EBV-associated smooth muscle tumors. These are very rare. I've never seen a case, but it is important to keep this differential in mind. This is seen in immunocompromised patients, and the myeloid staining is usually patchy, this patchy desmin positivity. The morphology of these tumors can vary from spindle cells to small round blue cells, is generally an inflammatory component, and the diagnostic marker is doing an IPGMER in situ hybridization test, which is positive. I'll just briefly touch upon the importance of US-guided FNA in diagnosing mesenchymal tumors of the GI tract. This is a very important recent, ancillary test that we have with us. So because we can approach these lesions through the endoscope, and an FNA is taken, if we do a cell block, that is our best chance of getting a confirmatory diagnosis by using IHC. And treatment of GI mesenchymal tumors are dependent on diagnosis on the US FNA or core biopsy. So and this is the importance of adequacy testing for these FNA and making cell blocks. Some differentials of the leiomyomatous tumor are this tumor, for example, which is not uncommon at all. We have seen many cases. So as you can see here, again a bland spindle cell tumor, but there is palisading of these spindle cells, and they seem to be forming these verrucae bodies, alternating hypo and hypercellular areas. That is not very apparent in this biopsy. So this is a schwannoma, and the typical verrucae body appearance does help us to morphologically diagnose these cases on a biopsy. And in a resection specimen, what we classically see is this lymphoid cuffing around the tumor. So that's a hallmark of schwannoma, which has to differentiate from the other bland, benign, other spindle cell neoplasms. And these tumors are S100 positive. Rare variant of schwannoma, which has been recently described for the GI tract, is the reticular and microcystic variant of schwannoma. Now, we came across one case like this in a pharyngeal biopsy, and there the morphology was almost identical to an adenoid cystic carcinoma, which this can mimic. So a differential of a benign versus malignant tumor had arisen in that case. Luckily, we had the benefit of IHC. So this tumor was nicely S100 positive, and it was negative for GATA3, which is and P63. So we could diagnose schwannoma of reticular variant for this tumor, for this case. Now coming to the second case, this was a 72-year-old male patient who presented with dysphagia, and endoscopic ultrasound showed a G junction submucosal bulge. The mucosa was unremarkable, and the CT scan showed a 4.5 centimeter lesion at the outer aspect of the G junction. As we can see here, a heterogeneous echo pattern, and the patient underwent US guided FNA. And these are the smears. Both the diff and the pap stain smear show bland spindle cell neoplasm. It's a cellular smear and not much pleomorphism, even at high power, and no appreciable mitosis or necrosis. The cells almost have a cigar-shaped nucleus, as you can see here. And this was the cell block, which showed these classical perinuclear vacuoles and the cigar-shaped nucleus. As you can see here also in the cell block, the pleomorphism is minimal and no appreciable mitosis at this power. On immunohistochemistry, there is a strong diffuse positivity for DOG1, CD117, and H-Caldes1. As I mentioned before, H-Caldes1 can be commonly positive in GIST. So, GIST is a very common tumor of it is the most common mesenchymal tumor of the GI tract. And based on the site, it is commonly seen in the stomach, followed by the small intestine, and rarely presents in the other parts of the GI tract. Extra gastrointestinal GI tract GIST is also seen. Incidence is as low as 1%, but in practice we see quite a few of these cases. Most commonly, GIST presents at 6th decade. There's a slight male preponderance. And most GISTs are sporadic tumors, but 5 to 10% of them can be syndromic. And these patients usually present with multi-site tumors. The syndromic ones have germline mutations, either in the KIT or the PTGFRA gene. They can also be associated with neurofibromatosis, Carney-Stratakis syndrome, which is GIST with paraganglioma, or Carney's triad, where the patient has pulmonary chondroma, GIST, and paraganglioma. So morphologically, most of the GISTs are spindle cell neoplasms, but some can also present with an epithelioid morphology, or we can have a mixed pattern of epithelioid and spindle cell tumors. The important thing to remember is that pleomorphism is very rarely seen in GIST. So if we are seeing a really pleomorphic, aggressive looking, lot of atypical mitosis, then it's very unlikely that you're dealing with a GIST. So that's one good clue to diagnosing these tumors. There can be morphological variations like sclerosing type, palisaded, vacuolated subtype, diffuse hypercellular pattern, or very hypocellular tumors where we see a lot of collagen globules or sphenoid fibers. And we even have ones where verrucate body-like areas are seen, which can mimic Schwannoma. So the IHC profile of GIST is CD117, which can be positive in nearly 80 to 90% of the interesting tumor that we occasionally come across. This was a 70-year-old male patient with a large pancreatic duodenal periampullary region tumor. The tumor comprised, as we can see here, nests of blue cells, around round epithelial-looking cells with moderate amount of eosinophilic to clear cytoplasm. And we can make out scattered mitosis here. There's a monomorphic look to this tumor. The cells have prominent nucleoli, vesicular nuclei, but seems to be monomorphic, like neuroendocrine tumors and like PNETs. There's a monomorphism to the morphology of this tumor. So this is a gastrointestinal clear cell sarcoma, or also known as malignant gastrointestinal neuroectodermal tumor, or GIT. So these tumors mimic clear cell sarcomas of the soft tissue, but they do not express the melanocytic markers. So they look like clear cell sarcomas, but they're negative for HMB45 and melan on IHC. So interestingly, they are commonly positive for the neuroendocrine markers synaptophysin and CD56. So if we are not careful and if we don't use a wide panel of markers, we may misdiagnose these as neuroendocrine tumors. The IHC to pick them up is S100 and SOX10, which are strong diffuse positive in these tumors. And they are defined by EWS break-apart, EWS mutation. And using FISH for EWS break-apart probe, we can pick these tumors, diagnose these tumors. Now, this is pretty common mesenchymal tumor of the pediatric age group. This is the third commonest tumor in children in the liver after hepatoblastoma and infantile hemangioma. So mesenchymal hamartomas not only present in the liver, they can sometimes be seen in the soft tissue around the liver, and diagnosing on a small biopsy is sometimes challenging because the morphology is a bit varied and a bit what we can see sometimes is just a biopsy showing a lot of loose islands of connective tissue. So in that setting, with the radiological suspicion of a mesenchymal hamartoma, it's very difficult to stamp these tumors. Rarely we get a resection for these lesions, and their diagnosis depends on seeing biphasic nature. So there's connective tissue component, and then there is an epithelial ductal biductular component, along with ductal plate malformation. And they present in very young children commonly. And also, it's a hematomatous lesion, so we see dilated haplocyte blood vessels, fluid-filled spaces. They somewhat resemble fibroadenoma of the breast in sections. There's a wide range of vascular tumors which can occur in the mesenchymal tract. They are very similar to the corresponding entities in the soft tissue, so I won't be covering the vascular tumors in today's talk. Especially the benign group, the hemangiomas are quite common. Hemangioendothelioma most commonly presents in the liver, but can be rarely seen in GI tract biopsies as well. Kaposi sarcoma, angiosarcoma, these are occasionally seen, and I will show you an example how they can come in the differential of other spindle cell sarcomas. Before that, case 5, this was a 6-year-old boy who presented to us with abdominal pain and a large tumor in the liver. He was initially diagnosed as high-dated cyst on radiology and was being treated for that. AFP was also normal, but then he underwent a co-biopsy, and it showed this bizarre morphology of spindle and stellate cells arranged haphazardly in a myxoid background, and some bizarre cells, prominent mitotic figures, and giant cells as seen here. So we did IHC on the biopsy, and the case was positive for Glypican-3. And by excluding other differentials, we could diagnose embryonal sarcoma of the liver. These are rare, but embryonal sarcoma is the commonest pediatric malignant mesenchymal tumor of the liver, actually. So if we don't see hepatoblastoma components, we don't see excluding other differentials, this can be diagnosed. There is no good marker to pick this up. Glypican-3 is, we were lucky it was positive, but only few cases show this stain. Sometimes CK and desmin can be focally positive, and they're negative for the liver markers HEPAR1. This is an aggressive tumor, but if diagnosed early and resected, they can have a good outcome. Our case was treated with chemotherapy and then followed by partial hepatectomy, and now he is still doing well 2 years after treatment. And this is the last case. This is a 55-year-old male who presented with dysphagia for 2 months. Endoscopic ultrasound showed a polypoidal growth occupying the entire lumen. And the biopsy was a spindle cell neoplasm. It was showing atypias, so we said query sarcoma. All the keratin markers were negative, and the patient was planned for upfront esophagectomy. So generally, if it is an epithelial tumor like a squamous cell carcinoma or adenocarcinoma of the esophagus, the protocol in our hospital is that the patient undergoes neoadjuvant treatment. So it's either neoadjuvant chemoradiotherapy, which is cross protocol for squamous carcinoma, or just neoadjuvant chemotherapy for adenocarcinomas. And then the patient undergoes resection. But because our diagnosis was sarcoma, the patient underwent an upfront surgery. And as you can see here, a large polypoidal tumor filling up the entire lumen of the esophagus. And this is the cut section. On microscopy, it's a very cellular spindle cell tumor with arranged in short fascicles and pleomorphic, prominent mitotic figures seen here. And on IHC, the tumor was positive for SMA, and CD31, which is a vascular marker, also showed a significant amount of positivity. The negative stains were desmin and caldesmin, the Maillard markers. All the keratins, PAN-CK, CK818, EMA were negative. GIST markers, CD117, DOG134, and S100 were all negative. So our differentials were, we couldn't stamp as a particular type of sarcoma, and we were wondering about angiosarcoma as well because of the CD31 positivity. And we also kept a poorly differentiated sarcomatoid carcinoma in our differential. And in one of the sections out of extensive sampling that we did from this tumor, we did find focal positivity of P63 in the spindle cell areas. And this is the CK. So, and this epithelial component in this section also shows dysplasia, which is highlighted by the P63 IC. So this was the origin of the squamous cell sarcomatoid carcinoma. So sarcomas are very rare in the GI tract, and we have to keep in mind that we need to exclude a sarcomatoid carcinoma before we stamp something as an undifferentiated sarcoma or undifferentiated, as an undifferentiated sarcoma. And squamous differentiation for can be very focal or can not be there also in certain biopsies. So that's all for, thank you.
Thank you, Dr. Roy. Wonderful presentation. Really wonderful cases. You've covered the entire gamut of mesenchymal tumors of the GIT in a very nice way with cases. Embryonal sarcoma of the liver, very rare. I mean,
Very rare. Yeah.
difficult diagnosis.
Yes.
Very, very interesting cases.
And very gratifying that the patient is still doing okay. We are hoping the child makes it.
Even the last case which you showed, Sarcomatoid carcinoma, I mean, with that extensive, workup, I don't think so all of us would be able to do all that. And then come up with a
we don't really need to do the workup, but we shouldn't exclude it from our radar of differentials, is all I wanted to point out for the PGTs, because think of common things first. So sarcomatoid carcinoma has to be excluded before we call, unless it's like looking like a typical GIST or Leiomyoma sarcoma or something that we know is matching the morphology and the IHC exactly, that's fine. But calling something undifferentiated sarcoma or spindle cell sarcoma without ruling out sarcomatoid carcinoma should not be done, and we commonly encounter this situation in the GI tract.
Correct. It is a very good talk for the PGTs. Everything has been covered, and whatever relevant and important is there has been looked into. I mean, in a very nice way. Very nice. Thank you so much. Wonderful presentation, Dr. Roy. Excellent. You've done a wonderful job. God bless you. Thank you so much.
Thank you very much.
Take care. Please share your PDF so that we can share with the students, right?
I will send it to you.
Thank you so much. God bless you. Take care.
Thank you very much for this. Bye-bye.
Thank you. Bye. Bye.